you hear me?
Yes.
Okay. Thank you for having me do this talk, Megan. So we can go to the next slide. So the objectives for today are to define pediatric palliative care. And because it's not as clear in terms of a definition as what adult palliative care is, when someone mentions adult palliative care, most people understand what kind of work is done. But in pediatrics, it's much broader in terms of conditions and also in terms of how long we care for the children. So then we have to explain a little bit more in terms of what kind of conditions of medical conditions what type of medical conditions of children who should receive palliative care. I'm going to discuss a framework for consultation that we find useful at Canuck Place Hospice, and I'm going to also review some areas of how we can provide care to this population of children. Next slide, please. So just reading this descriptive definition first, pediatric palliative care prevents, identifies, and treats suffering children with life-threatening conditions, their families, and the teams that care for them. It is appropriate at any stage of the illness and can be provided together with disease-directed treatment. So in other words, they can be pursuing curative treatments, but at the same time receive palliative care. Next slide. And so if we break this down a little bit more into the different criteria we often use in terms of which children we care for, typically the age range is from birth up until about 19 in our setting. Sometimes with some pediatric conditions, we go into the low 20s. And all of these children would be living with either a life-threatening condition or a life-limiting illness. But the key is often this condition is progressive. So it has to show some degree of progression where there's ongoing deterioration of health or change in functional status. That doesn't mean that even if a child progresses, they could still have some improvement and do better for a period of time. But if you look at the trajectory of their entire course and you plot it out, they are progressing over time, even if they show some improvement and then go back down. So in other words, they have conditions for which there's a likelihood of death before reaching adulthood, defined as early 20s, and again includes those for which curative treatments may be feasible but may fail. So in South Asia, this criteria, for this criteria, about 55 per 100,000 children in South Asia, based on this definition, would need palliative care. Next slide, please. So it's easier because we look after so many different medical conditions over long periods of time, sometimes for hours and days, sometimes for months to years, and sometimes for many, many years, and the children reach adulthood and may even graduate out of the program. So it's easier to look at this in terms of what kind of conditions of children that we actually look after. There's 4 categories of children who need palliative care. And I'm going to break it down into each different category and talk about which medical conditions fall into these categories. Next slide, please. So the first category are life-threatening conditions for which there is a cure, but for everything that we treat, not all treatments are successful. So there is a treatment, but it can still fail. So most medical conditions could fall under this category, but one of the big categories would be oncology or cancer. So from what I learned from being in India, my understanding was that the mortality rate for pediatric oncology is closer to 80%. And so there are some cancers that you can treat, but still the majority of which you cannot treat. So this would fall into this category. Cardiac disease would fall into this category, depending on whether a repair is possible or whether a repair fails. Certain infections, which depending on how severe the infection is and the delay in treatment or how effective the treatment is, could result in a palliative condition, such as meningitis, cerebral malaria, or multi-drug resistant TB, and some blood diseases such as thalassemia or sickle cell. So you can see that that there are treatments available for all of these conditions, but the effectiveness of the treatment may be variable based on the population. Next category, next slide, please. The next category are conditions which are still ultimately terminal, but there are things that you can do and intensive treatments that you can provide that is actually effective in prolonging life and providing some quality during that time. So so in this category, we used to at least in Canada see cystic fibrosis in the pediatric setting, but now with the treatments, we don't see cystic fibrosis in the pediatric setting anymore. HIV/AIDS still falls into this category, but perhaps in the future this will go into category 1, or is already starting to move into category 1. So a large population of the muscular dystrophies or neuromuscular conditions would fall into this category. So the most common of which we at Canuck Place have a lot of this population on our program, would be the Duchenne muscular dystrophy children, where they have progressive weakness over time, but there's interventions that could, such as steroids and proper nutrition and sometimes non-invasive ventilation, which help them do better over a long period of time. Another category would be either chronic or severe respiratory failure and severe immunodeficiencies. So you can see in this category, there are treatment interventions that you can introduce that help the children live longer. Next slide. The difference in category 3 versus category 2 is in this category, these are progressive medical conditions where there aren't very good treatments that help prolong life. So in this category, you can help treat the symptoms, and by helping treat the symptoms, the children you can help decrease the complications and perhaps help them live longer, but we're not changing the course of the disease. So for example, we can help manage the seizures, we can help with feeds, but we can't change the course of the illness. So the big category here would be inborn errors of metabolism or metabolic disorders, such as mucopolysaccharidosis, Tay-Sachs, or mitochondrial disease. Another category would be the neurodegenerative diseases. So these neurological conditions, they're going to progress over time, and you're managing their symptoms. So one example would be Rett's or adrenoleukodystrophy. Some of the more severe chromosomal abnormalities, such as trisomy 13 or trisomy 18. And so some of these babies that are born, some live for months, some live for hours, some might live for years, depending on what systems are involved. And the last category example in this area would be neuromuscular diseases, such as spinal muscular atrophy, where the baby is born with a defect in the anterior horn cell, which it results in severe weakness, especially involving the respiratory muscles. Next category. And so when we look at category 1, 2, and 3, those are more clear conditions where we would say if the children have these conditions, that palliative care would be involved. Category 4 is a little bit more gray because there's a huge spectrum of children that fall into this category, and they have to show, they have to be more severe and show some degree of progression before we say that before palliative care would be involved. So these children have severe disabilities that lead them to be extremely vulnerable, very fragile to complications and premature death. So a very, very large category in this area would be severe cerebral palsy. So when we have the milder forms where they have less issues with their swallowing, less issues with their lungs, they're more mobile, then we wouldn't consider them palliative. But if you have a child who is highly dependent, has difficulties with swallowing, is at risk for aspiration pneumonia, is seizing all the time, is non-mobile, this would be someone that we would look after in the pediatric palliative care setting. And then all the other ones are looking at like brain CNS abnormalities or CNS dysfunction. So you could have neurological consequences of infection, cerebral infections such as meningitis, complications from HIV, or you could have some sort of anoxic brain injury, for example, hypoxic ischemic encephalopathy from asphyxia at birth, drowning, cardiac arrest, or brain damage from a traumatic brain injury. Or you could be born with severe brain malformations, such as the different cephalies, and also very, very severe hydrocephalus, where you might not have very good brain function. So you can see in this category, the main theme is that they're very neurologically compromised. And because they're very neurologically compromised, there's significant risk, especially from a respiratory status and from seizures. And so there's a large population of these children that we look after for a long period of time. Next slide. So this graph is from the Global Atlas of Palliative Care at End of Life through the WHO, and it shows the different conditions, and you can look yourself in terms of the percentages of the different conditions that of children who should be receiving palliative care. Okay, next slide. So, so we talked about all these conditions, and I just wanted to show you this slide, this graph, which shows different pathways of disease progression leading ultimately to death. So time 0 on the bottom axis is death. And so these are different ways that children can progress. And I want to highlight to you where the purple line, the y-axis is quality of life. And you can see when palliative care is involved, that's where the purple line is. And when pediatric palliative care is involved, the children live longer, and also they also have an improved quality of life. And so you can see from the different graphs, and I can give you some examples of conditions that fall into these categories. So condition A would be a sudden accident. So you have an acute event and you suddenly die. So there, in this scenario, there's no opportunity really for palliative care to be involved other than in bereavement. Graph B shows that a condition with very steady decline. So for example, a mitochondrial disease or chromosome or an inborn error of metabolism, they might decline over time, or certain malignancies might fall into this category as well. Graph C is you can see that there's decline, but then there might be treatment which might help you get better, but then the treatment eventually wears off and then you're declining it again. And so a very good example here would be cancer, because if you offer chemotherapy, you can see that they improve, but that if the chemotherapy is not curative, then they're going to decline again, and then they gradually progress. And then graph D is a large population of children that we look after, and then these are the children that we say are very medically compromised and very fragile. And so, and one example would be someone with very severe cerebral palsy. So you can imagine that they're doing well, but then they get an aspiration pneumonia. And then during that aspiration pneumonia, they might have the possibility of being very well and then have the possibility of actually dying. And if they live through and they're able to recover from their aspiration pneumonia, they might improve back to where their baseline was until the next episode. So you can see that these kids are living a roller coaster where they might be well, but a very mild illness or certain illnesses can easily set them off. And so these are what we call the very fragile children. Next slide, please. So this is a framework that we use at Canuck Place for our consultations, and we find this very useful for initial consultation or when we're revisiting. If we haven't seen a family for a long time, we revisit this again so that we have all the information to provide care and also to communicate with the rest of our team. So the first category is physical. So physical is basically all the medical issues. So in terms of medications, all the conditions, feeds, etc., everything medical. And the second category would be social. So who is in the family, their siblings, do they go to school, what are the medical facilities in their area, what are the community supports in their area, what kind of supports does the family have. Emotional would be emotionally, how is the child themselves doing? Oh, can you go? Yeah. And then spiritual would be either religious or where the family sees the journey of their child in terms of where things that are at and what kind of quality of life they have. And trajectory is looking at goals of care. So in terms of talking about advanced directives and planning for changes in condition, whether they're stable or whether they're progressing. Next slide, please. So how do we care for these children? And I've taken this slide from Megan because she obviously has a better understanding of the local context than I do. So community-based care, and I think this is the majority of where a lot of the pediatric palliative care is being provided is in the community and with home-based care. Where the next level up would be district hospitals, where there's general palliative care skills, often from you guys with adult palliative care expertise, and tertiary hospitals where there's pediatric palliative care expertise, either in an outpatient setting or in inpatient units. And then in areas where there's hospices, whether combined adult or only pediatric, then hospices can also provide the care. Next slide, please. So I wanted to kind of go over some of the areas of care that we provide, and this is these are slides from Canuck Place, so some things will apply to your setting and some things may not. So one aspect of care that we provide at Canuck Place is medical respite care. So families can bring their children, their complex children, into the hospice, and then they have a period of time, in our case, 20 days a year, where we provide all the medical care so that the family can have a break or have a rest. And so you can imagine some of these children. So this is Charlie Ann. She has spinal muscular atrophy type 1. She's extremely weak. She's on BiPAP at night. She's GJ2 fed, and she has very weak lungs. And every time she has a viral illness, she's admitted and has intensive respiratory support. And every time she has a viral illness, the parents always worry as to whether or not that's going to be the time that they're going to lose her. And so you can imagine the complexity of her care. So the parents often need some sort of a break from the care, so then they can bring them in, and then we provide the care for them, and so that they can have a rest. So that's medical respite care. Next slide. And pain and symptom management. So this is the next category of care that we provide. So managing all sorts of symptoms, whether it's escalating pain from progression of a cancer, or in this case, Dominic is a child who has a metabolic disorder. He's aspirating all the time. He has difficulties with his secretions. He has seizures. And so the parents are often calling us to help manage some of these symptoms. And if we are able to do it at home, we do it at home, either by phone or home visits. If we are not able to, then we would bring them into the hospice so that we can have an intensive period where we could work with the parents and also communicate with the community teams to help try to improve the medical care to make him more comfortable and manage some of his symptoms. Next slide. And of course, end-of-life care, which is very clear when you're talking about palliative care. And so end-of-life care, whether it's in hospice, in the home, or at the hospital, we support the teams and support the families in providing end-of-life care. Next slide, please. And then mobile clinical care, which we're trying to develop, but I think you guys use more in your setting, which is what the families want, and it provides very good care, is to be able to have the ability to go to the home and see the families, see them in their setting, and then work with the child inside their home setting. And so this is Vivian. She had a very rare form of brain cancer, and she was diagnosed at around 2 months of age, and the oncologist didn't expect her to live very long, but she lived until 10 months after her diagnosis, and we supported most of her care at home until she passed away. Next slide. And then after the death, then grief and bereavement care, providing grief and loss counseling, and we support families for about 3 years after the child's death in helping with their the parents of the child and also the siblings. And next slide. And one other area that we help families with is with perinatal palliative care. So when there's a condition which is diagnosed, which has the potential of a baby born with a life-threatening illness, for example, trisomy 13, trisomy 18, pre-identified brain conditions like lissencephaly, like we mentioned in the previous slide, severe hydrocephalus, or certain multiple genetic abnormalities, then we meet with the families beforehand to make a plan to support them through the pregnancy, to support them at the time of the delivery, and then to support them with management of the child afterwards, both medically, socially, memory making, and then eventually in bereavement. And some of these children continue to live, and so they just continue on with us in our palliative care program because they continue to live for many years. So this is another level of care that can be offered. Next slide. Any questions?
Thank you so much, Peter. That was really good. And I commend you for staying on time, because that's not easy in this, to talk about such a big topic in such a short time. So